So guys, thank you so much for taking the time to join. Thank you all the participants, and thank you panelists, speakers. I'll just give a very, very brief introduction. I'm sure you guys need no introduction. So I'm gonna start with Jay Kishan, a good friend. He's from my alma mater. I train at the Cleveland Clinic. He's the director of Cleveland Clinic Complex PCI program, and he works in the main campus, a native of Ohio. So thank you for joining us. Simon Walsh is from Belfast. Really, once again, needs no introduction. Global CTO expert, authority on the hybrid approach, involved in the consistent trial, does live cases routinely. Again, a really good friend. Thank you for taking the time. Sudhir Rathore trained at the birthplace, I should say, in Japan of CTO PCI, Toyohashi. Again, widely published in CTOs. Once again, a CTO expert. Dr. Anil Dal is Director of Cardiology at Delhi Heart and Lung Institute, and he's he was retired. He's ex-armed forces, so truly an honor to have you here. Recipient of the Sena Medal from the President in 2005. Ajit Pillai is the head of Department of Cardiology at JIPMER, one of the leading CT operators in the country. Dr. PKG, once again, needs no introduction, professor and head of the department at STPGI, and one of the founding members of IJCTO. Dr. Azam is a friend from Bangladesh. He has trained several cardiologists and fellows in complex coronary interventions, and he is a course director and national organizer of the SKY Complex PCI program, most recently in 2019. So, we got did I miss out anybody? I just want to be sure. So there, PKG. Okay, I think I got everybody. So guys, thank you so much for coming. I won't make this super formal. Let's just dive into the first talk. None other than Dr. Simon Walsh.
Thanks, Arun. Thanks for asking me, and to everybody for involving me. So I'm going to share my screen here, I hope. Okay, so Arun basically has asked me to discuss the risks and mitigation of risk, really, in terms of CTO PCI. Are you seeing the camera boxes on the right-hand side, or have you just got the presentation?
So we can see the presentation?
Yeah, okay. We're good. You're good.
Everything's fine. Okay, good. So I'm just going to go through this in a systematic way and to try and get people to think about how they can take simple steps, really, that will mitigate risk and prevent complications rather than having to deal with them. We know that CTO PCI is associated with a higher rate of risk than a standard PCI procedure, and that is what it is. It just reflects the complexity of the problem that you're faced with. But there are two ways that we can obviously, I think, mitigate a lot of risk. And the first one of those is bleeding. And I think the concept now that we need to be involving femoral arteries for CTO PCI is a bit of a misnomer. And certainly over the last couple of years, I've switched to as much a purely radial approach as I can manage. So bilateral 7 French radials are feasible in our population. Maybe not so much in all of Asia, but for us, it's definitely feasible. So we don't need to use 8 French access anymore. And I think taking the femoral aspect of this procedure away is a good safety step as well. I think strategy is another thing that we can, take sensible choices with. And we do have lots of options within CTO PCI nowadays. We've got a ton of good equipment, but we still only have 4 basic ways to approach the lesion. So we can go through the lesion in lumen, antegrade or retrograde, or we can dissect antegrade or retrograde, and that is what it is. When we make those choices and we apply the algorithmic approach to it, we do have to accept that there are different risks associated with each aspect of the procedure. And often there are 2 or 3 or even 4 options for a specific CTO. So understanding what the limitations of each approach might be and where problems might arise, I think, is quite important. We also have data as well, and these come from Manos Berlakis' group and mainly US-based registry, which show that if you do take a retrograde approach, that your risk of MACE and certainly tamponade is increased. So we have to, I think, respect that and be sensible whenever we have different options available to us. So when there's only one way to do the case, okay, you've got to go that way. But when you've got multiple choices, I think you try and take the one that's the most sensible for the patient, and that's important. And perforation then is the other thing that creates the major worry. And if we look at open-CTO, which was completely audited, core lab for everything, is very honest appraisal of where we are in terms of complications. Recharge, it looked a little bit less, but we didn't have the same level of auditing of outcomes in recharge. Basically, your taponade rates are somewhere in around 1 to 2%, depending on which registries you're looking at. And I think one thing that algorithms don't tell us is what's safest. So they'll point you in a direction to try and make your procedure efficient, but they don't necessarily give you the safest approach that is available. So if it takes a little bit longer to do something antegradally, rather than risking a silly collateral, I think that's what you should try to do. So a couple of cases, and I hope these videos will project and play okay over the internet. So here's a case. We've got a right coronary artery CTO, epicardial collateral going across from the LAD. There's an anomalous circumflex, and the anomalous circumflex also gives off squirrely small collaterals. If we look at the target vessel, the bifurcation reconstitutes close to the crux. And if I just go back a couple of pictures and show you this one again, you can see on the top of it that there's a tiny little branch, then there's a bit of the main right coronary, then there's the PDA, and then there's the PLV. So how should we approach this specific lesion? Well, we have choices. I mean, we can get round these epicardials, but they risk ischemia. And if you have a perforation or a problem with them, you potentially risk an infarct. So for me, the preference for this type of case is actually antegrade and ADR for a long CTO, rather than retrograde and messing with those collaterals and causing problems. And you can do these cases with ADR fairly straightforwardly. So we are accepting that we're going to lose that teeny little branch before the PDA, but we're able to re-enter successfully from a stingray and then to reconstruct the vessel with a good outcome and a good level of revascularization. However, we're trying to stay as safe as we can, but even with the best intentions, we actually did have a cross-bus exit to a small intramyocardial area. Didn't create any specific problems for the patient, but it's making the point again that you just need to be aware that these sort of things can arise, and you need to have everything to hand and the experience to be able to deal with them should they occur. This is case 2, and it's the other way around. This time, we've got a lesion with quite a lot of calcification in the distal vessel. There's a whole lot more of the right coronary artery proximal to the bifurcation. And you wonder, is this a decent case for ADR, or should we consider retrograde for it? And what we have tried to do is to wire out first. Antegrade wire escalation has been unsuccessful. You can see that the wire has spiraled outside the vessel, distally there. So what next? Should we consider ADR, or should we consider retrograde? And for me, with the amount of calcification and the amount of disease distally, I thought that retrograde was going to be a better way to guarantee a success here, rather than wasting time, money, and equipment on an ADR case that would be relatively high end. So there's a hierarchy of risk with collaterals. So we tried septals, unsuccessful proximally, unsuccessful mid-septum, and eventually actually wired from an epicardial collateral across. So we have this epicardial connection from a diagonal branch over to the PLV. And this is a CO03 going across. It's a lovely wire, very gentle, very safe. I personally haven't seen any perforations from it out of an epicardial or anything else. I don't know if anybody else has, but it seems to be a very safe wire. So we're able to get retrograde. We're able to successfully complete, and we have IVUS optimized reconstruction of the vessel and a good result. However, on the way to a good result, we got a septal rupture, an epicardial rupture, and that had to be coiled. And, again, just make the point that these things may happen and you need to be aware, you need to be ready and just basically be able to deal with them should a problem arise. So 2 coils are put in there and the patient has no issue, no significant leak, and no problem after the procedure. So I think we do need to carefully balance what we're doing with strategy and our choices. We want to absolutely do a case that's going to be successful and efficacious. We also want to consider efficiency, but I think the lowest risk is one thing that we should absolutely put into the risk, into the overall decision-making paradigm. And if you're not considering risk, I think you're not doing the right thing by your patient. And strategy does give you predictable situations that you can avoid in terms of what you're doing. So here's a case of Lima being a last remaining vessel. It's a horrible long right coronary CTO. We have to do this with retrograde access. We've actually tried to open the native LAD unsuccessfully to get to a septal, and we're left with the Lima itself being the only option. So we've got a very long occlusion. We've put an impella in. We've taken every step we can, and we accept the risk of using the IMA. And the problem with this vessel is that it's very tortuous. And if you go down a Lima that's tortuous, you need to be prepared for problems. And even with the impella in, as soon as we put the wire down the vessel, it actually kinked. So that looks like it's an acute occlusion. It's just that the vessel has kinked and nothing more. And that's what happens to the patient's pressure. So, using these things is not always feasible. Basically, we just had to stop, and unfortunately, we couldn't revascularize that patient. It is one of those things. You can't get them all, but you do need to be prepared and to take steps to mitigate against risks. You can see once we withdrew everything there, actually had a wee bit of a dissection with the guide. We put a stent in the IMA and everything was fine. The patient recovered his pressure and there were no further issues. I think there are some specific things with antegrade approaches that you need to be wary of. And the same thing applies in CTO as in every other PCI as well. So you need to pay attention to guides, guide catheters, guide catheter extensions, guideliner, guidezilla, and so on. And you need to pay attention to your waveforms. This was a case that was set up for PCR in Bristol, and we had a very experienced international operator who basically started the procedure and injected too hard through a guideliner and dissected the entire vessel from top to bottom. And that's just a basic mistake that we don't need to make. So I think being aware of these sorts of things and do think carefully about them and stay alert and awake during your procedure is important. I think with the anatomy, you need to be certain of where you're going and what you're doing. And certainly with wiring, it's probably the most jeopardous part of the procedure at the start with the proximal cap, and your risk of going out of the vessel is significant. Here we've got a right coronary artery. Doesn't look like the longest thing. There's a funny little squiggly branch close to the proximal cap. And this is one of our fellows. Normally I show complications are my own, but this one wasn't actually me. And the question is, where is that guide wire? And I think the critical eye can see that the tip of the guide wire is just moving in a slightly different way than the vessel. So the right coronary is going in a different direction to the wire tip itself. And it's a little bit more apparent when you look at the RAO view that things just aren't right. So caught on to the fact that he wasn't in a good place, did actually successfully complete the case, but at the end you see a contained perforation. And it's very easy for those sorts of things to turn quite nasty. So I think being absolutely laser focused on where your equipment is in the artery and being sure you're in the right place is crucially important within CTO PCI. This is not a case of mine as well. There's a functional occlusion of a distal LAD. A guide wire has gone out subintimally. The operator is inexperienced with complex PCI and doesn't actually realize that that wire is not in the vessel, and then makes the very crucial mistake of dilating into that space. And that's purely from not understanding that the wire has been incorrect from the start. And you can guess what's coming next. A fairly horrible exit with a lot of pericardial effusion. So this patient got very sick very quickly, as you might expect. So you can see the guide wire there is nowhere related to the LAD at all. Those sorts of things, again, avoidable if you take your time and understand where the anatomy is. Proximal cap is another issue. Often it's quite ambiguous. There's usually little branches associated with them. And understanding where the proximal cap is another point of the procedure that I think you need to be careful with. So here we've got a right coronary occlusion. It's autocollateralized post-CABG. And we weren't sure what direction the vessel goes in. You get it wrong, bang. So there's a perforation as well. And you can prevent these fairly easily simply by either dissecting before the proximal cap or actually by demonstrating where it is with an IVUS. So if you put your IVUS into a side branch, which is big enough to take the catheter, you can usually demonstrate the origin of the CTO itself on the IVUS. It takes a little bit of time to get your eye in to get used to looking at those things, but once you teach yourself how to do it, it's a very safe thing to do and often makes the procedure a safer and better thing. Blunt dissection, I think, is always safer. It's very unusual to be able to exit the wire with knuckle wires into the pericardium. So if you're uncertain, base maneuvers and so on, get yourself into the vessel architecture and stay blunt dissection rather than poking stiff, pointy things is usually safer. Knuckles can go wrong. And the thing to watch out for is what we call an exploding knuckle. And you look how large this knuckle wire grows here. So that's clearly not doing the right thing. The knuckle becomes excessively large. So when you see that sort of thing happening, you've got to start over and make sure you're in the vessel architecture. So that's wrong. Crossboss can follow branches. Here we're obviously tracking a little RV branch at the margin. And the way to resolve that is actually to come back and redirect with the knuckle to the main vessel. But you have to recognize the fact that you're outside of the main vessel architecture and you're tracking an RV branch. As long as you understand what the problem is, it's easy to resolve. And then things like the landing zone. I mean, you don't want to give a big blast of contrast from an antegrade catheter and create a hydraulic dissection that takes out the distal end of the vessel. This is a case that I'm doing, and it's actually me that injects through the antegrade guide catheter, and we have an extension of hydraulic dissection at the end of it. And unsuccessfully, unfortunately, now we can't do re-entry for that case, so it was stopped and the patient came back another time. But take the antegrade contrast syringe off, or be careful with labeling if you're manifolds, but be certain that you're not going to give contrast into the wrong vessel. It's a very easy mistake to make. So here in this case, the antegrade guide catheter syringe is actually taken off and disconnected, and that means you can't do that. And then retrograde specific considerations are important as well. And I think the one thing that we're all crucially worried about is collateral perforation, particularly with epicardials, and that is absolutely important. But there are other potential issues. You can injure the donor vessel, which is potentially a very bad thing to do. If it's a left coronary, you take out a left main. It's dangerous for the patient. You can entrap equipment. You can do other things as well. So you do need to be careful. So here we have a very good operator, one of our senior fellows at that stage. He's now a consultant in London, and he's early in his retrograde learning curve. And what happens is, as he's retracting the equipment, you can see that the guide there has trashed in to a stent in the left main stem. And unfortunately, that creates a longitudinal stent deformation in the left main, which is shown here on the IVUS. And as the IVUS pulls back, you'll see an involuted double layer of stent at the left main ostium. Now, we've recognized it, and that's simple to resolve. All you've got to do is post-dilate it again. But it's very avoidable by leaving the retrograde guide catheter far away from the left main as you retract your equipment and bring things backwards. So redilate, resolve that particular problem, and you can see the IVUS shows a nice result, and that stent is not deformed anymore. There's a little bit of compression, but it's resolved, so that's fine. Donor vessel is important. You can get kinking and you can get thrombus, damped guide pressures. All of these things are important, but being very, very careful with your ACT is important. So it's got to stay over 300. And I think, if you've got moderate disease, which is going to cause a problem during a retrograde approach, have a low threshold, actually stent it and treat it so it comes out of the equation of risk for the patient during the procedure. So this is an LAD that's gone down during a live case, and that's from thrombus, which is resolved. The patient gets bradycardic, gets ischemic, has anterior infarction ongoing, which is not what you want when you're dealing with the right coronary artery. So do pay attention, watch your ACT very carefully. Retrograde procedures can go long, and you don't have to do retrograde all the time, particularly if you've got other options. So use those when that's appropriate. And I think the hierarchy of jeopardy is important. And if you're choosing collaterals, diseased vein grafts that are open, well, you can't miss. Septals are very safe. It's unusual to create major problems, although it can be done. Occluded vein grafts are often of use if they're only occluded within 1 or 2 years. Epicardials are higher risk, and lima, and particularly tortuous lima, avoid until the very last option if you can. How do you avoid collateral perforation? I think, well, I mean, Jay's going to talk to us about perforation, so I'll not steal his thunder, but if you have an antegrade option, you're not going to get a retrograde problem. So that's obviously the first thing. And know when to stop, and that is experiential, but if things aren't going, especially in epicardials, stop and find another way. It's always the safest thing to do. Equipment entrapment is what happens if you spin knuckles. So you can actually knot guide wires, and you need to be very careful. And freeing up things like this is very difficult, and that can make a bit of a mess when you take them out as well. So don't spin things. Knuckles are just pushed and advanced. And if you do get things that end up being entrapped, it's often safer to balloon them free rather than to pull very hard. That can make things worse. So manage your knuckles carefully. Don't let the microcatheter get far away from your knuckle. Beware of kissing equipment, particularly balloons and a retrograde microcatheter and the Chinese finger trap. So don't dilate too close to it. And if you don't stent on a non-externalized wire whilst the retrograde equipment's in place. So you've got your RG3, you throw a second wire down, and then you put a stent in, you can entrap the RG3. So those are all simple things to do to prevent you getting into trouble. So I think a lot of these risks are predictable. I think the operator has the potential to control them right from the get-go at the start of the procedure. I think we do have to be prepared to deal with consequences of the decisions. You need to have all the equipment to bail yourself out, and you also need to be familiar how to use it, particularly with coils and collaterals if you're going to do higher end epicardials and so on. And they may be the only way to do it, and if that's the case, so be it, but be prepared to deal with the consequences of those decisions. So with that, you've got a lot of these sort of videos and explanatory diagrams in the iBook if anybody wants to go to it. And I'll stop and open up the discussion with the panel.
Simon, thank you so much for that wonderful talk. We know Simon's one of the best operators I know on planet Earth. And that was a great talk on avoiding complications. First, I think you kind of hit the nail on the head. Don't do it if that's a safer option. You have to be willing to deal with complications if you're going to do CTO PCI. I think knowing when to stop is always a good thing for anybody. And I think one of the key points that you said was, do not follow gear after a wire when, if you don't know where the wire is. And again, fantastic talk. Thank you very, very much. There are a couple of questions that have come up. Any comments from the panelists? And hey guys, in the interest of balancing everything, so you guys are welcome to answer some of these questions to the group so people can kind of see the answers. If you feel something needs to be answered by talking, just go ahead and say answer live and then just talk about it.
Hi, Simon. Can you hear me?
Hi, Sudhir.
Yep.
I can hear you.
Hi. Great talk. Yes, it all makes perfect sense. You've got so much data available from multiple international registries adopting different algorithms. So is there, in your mind, is there any signal from one registry to other registry? Because some registries are just retrograde predominant, and some registries have got a mix of hybrid algorithms. Is there any signal in your mind? Obviously, these are different patient sets, different operators, in terms of adverse cardiac events from one registry to other registry.
It's always so hard to understand, Sudhir, because of the level of underreporting that we naturally have within registries of complications. Things that maybe a core lab are going to pick up that don't compromise a patient or lead to an adverse event typically don't make it into a registry. So I'm always a little bit wary of trying to sort of say, country X or approach Y or whatever is better than one thing or another. I think the only true properly audited data that we've had in terms of complications actually comes from open-CTO, and they're basically a lot more common. And that trial was, it was core labs for everything. There's no hiding of anything at all. Everything was reported, and I think we have to accept that that's probably where the level is, and anything else out there is likely to be underreporting.
I completely agree, yes. And I think some data has shown retrograde with slightly higher complication if you tease it out. Obviously, it's an observational data. So I think one has to be careful and go for the safest option available in that individual patient, and also on their expertise, basically. If somebody is more
Yeah.
experienced in antegrade techniques and ADR as compared to retrograde, then it's better to adopt that technique.
Yeah. And
Your
nothing.
point is, sorry,
Guys,
Simon.
Go
So
ahead, Jack.
I like Sudhir's point about the expert operator. The expertise of the operator in open-CTO was without question. I mean, these are very, very high volume operators throughout the US, and you can see how much higher the complications in an audited registry were compared to what is in a self-reported registry. So that's eye-opening.
Yeah,
Dr.
for sure.
Goyal, one of the questions that has been asked is, does the presence of bridge collaterals technically exclude antegrade approach, and do you have to go retrograde? So again, Dr. Goyal does a lot of retrograde, so we can kind of get his take on it.
Actually, this is an important thing, that sometimes you see a lot of collaterals and you feel that maybe this, actually I would say that I have seen collaterals even with recent occlusions. So collaterals doesn't really tell us. That is what my experience says. A good strong collateral doesn't really force me to go retrograde. I would still explore the antegrade option, and I tell you, we are successful majority of cases antegrade, even with good collaterals. And the good and strong collaterals in several cases you will see are also there in not too old occlusions, pretty recent occlusions. And so that is the observation. I was trying to study that to just a couple of days back. We were discussing, why don't we analyze our angiograms, how many the collaterals and the strength of the CTO. So I would still go antegrade. Well, if it doesn't work antegrade and you have good collaterals, you will switch to retrograde rather soon with a lower threshold. So that's what it is. And I think this is a very well said points by Simon, that you have to have all the three options. Think about the possible options, do the easiest or the best for that patient first, and then have something back up in your plan, what you want to do second and what you want to do.
Yeah, I think, and the overriding thought is always safety, isn't it? You know, that it's picking, if you've got multiple connections to use retrogradely, it's pick the lowest risk ones first, even though they're actually
right.
maybe potentially more difficult, or you may not be able to see a septal connection, but there still may be one. So it's always worth trying septals to get back to the right, or to get a CC0 connection is going to be associated with quite a lot less jeopardy than going through a crazy epicardial.
That's a great point, Simon. But you know, as technology is advanced and as we have more slow O3 available, and we look at even smaller epicardial channels and try to seek them out by not going for the CC0 or CC1 septal collaterals. And this is an inherent hazard of the evolution of our technology and the easy availability of SUO03, I think.
So, Ajit.
Thank you, Simon. Can
Guys,
I?
I'm sorry to okay, two things. One, I'm going to just answer this one question unless there are any comments that are like really pressing. The question really was, if they're bridge collaterals, do you have to go retrograde? I mean, Ajit, you're being kind of quiet. I know you do a lot of CTOs. Does the presence of bridge collaterals force you to go retrograde, or would you still try antegrade?
Bridging collaterals per se, I don't think force you to take a retrograde route. Of course, it will depend on other morphological parameters as well, the length of the CTO, the angulation. The one Simon was showing actually is a very kind of Shepherd-Brook RC with a very proximal bridging collateral, which is a very unfavorable morphology we will try to go for retrograde. I think there is no clear-cut answer to that question, Arun. I think it is not. It's a comprehensive assessment of the entire morphology other than the bridging collateral alone. The answer is actually that alone may not be the deciding factor.
Just a request to the panelists, if you can answer the questions, make sure you send it to all attendees and panelists. So, and there are some questions that can be taken, because I think there are lots of questions popping up as we speak. So Hey guys, it's 7:35, so I'm going to move on to the next talk,
Yes.
and then we can kind of save some of the discussion towards the end, if that's okay.
Of course, yeah. That's good. We can move on to the next talk, yes, and
All right,
we can
thank you,
carry on
guys.
with the discussions then.
Okay, so just going to talk about retrograde CTO PCI, the steps. Hoping everyone can hear me. Okay.
Yes, go ahead.
Yeah.
Yes.
All right. Okay. So we're going to talk about the basics of retrograde. Some of the like what are the steps. No extensive discussion on equipment in the interest of time. We'll kind of just look at one or two cases, depending on the time, to see to see what the steps are, and maybe touch upon some essential skill sets. So again, won't belabor this point. You guys are all familiar with the hybrid approach. There are times when you have to go retrograde and you really don't have an antegrade option. And I think it's an important skill set for people to know if you're really going to be a CTO operator. So the basics really are as follows. You have to essentially gain access to that part of the vessel beyond the CTO segment, right? So you can use one of the collaterals or a bypass graft for achieving this point. And then you got to cross the CTO. Most times it's both antegrade and retrograde, but you got to essentially cross the CTO and gain true lumen access, proximal and distal. And then, of course, you got to finish your PCI. And this can be done over an externalized wire, or you can convert it into an antegrade system and then get all the gear out safely. So basics again, dual access, typically don't pan, set up your shots, and then get going. Know your wires. I'm not going to, again, discuss this at length, but I mean, you should be familiar with the Asahi line of wires, the Sion Blacks, XTRs, typically, Suo 03s, and now Boston has an entire set of wires. The Sentai family of wires, the Samurai RC, specifically designed for retrograde, for surfing, which again, we can get into a whole debate depending on which school of thought you follow. I tend to surf, and I think a lot of the Western operators do, especially in septals, not in epicardials. Again, there are certain wires that we prefer when we want to septal surf. Sion Black has kind of replaced FC for me because of the Act1 core technology. Samurai RC can also be safely used for surfing. And when you really, really want to deal with tortuosity, again, I think Suo 03 is probably a go-to wire. Sion's still the workhorse retrograde option. And again, know your microcatheters. I'm not going to discuss this at length, but again, when you're going retrograde, make sure you take the 150 or the longer microcatheter, not the shorter one. So just again, different microcatheters have different properties. Some can be torqued, some are more of push microcatheters. And we'll kind of go over the step-by-step. This was the case I did last year. So again, this is the setup shot. You have a RCA CTO, pretty juicy collaterals, fairly long calcific proximal part of the vessel. Distal cap was kind of at a bifurcation. Okay, and there had been a prior attempt that had failed. So it's a pretty long segment, unambiguous cap, fairly calcific vessel, and the distal cap at a bifurcation. So before you start, before you embark on anything, I think as Simon really well explained this, have a plan. You got to know what's your option A, option B, option C, and when do you want to stop. So in this particular case, and often what we end up doing is prepare the antegrade vessel. I almost always, if I have the option, even if I'm going to go retrograde, start antegrade. And in this particular case, again, I thought, well, I didn't have the actual PCI angiogram attempt before. So I thought, all right, let me get going. So this is preparing the antegrade segment. There was no attempt at all to wire this. The plan was always knuckle, given the length of the lesion. So what I noticed was, even as I started doing this, I could not get, you can see the guide extension catheter. The guide was getting kicked out as I tried to advance it over a balloon and whatever else. So advanced the microcatheter over the wire here. So this is all just prepping the vessel initially, right? And so once this was done, take it as far as it goes, and then don't waste your time. We know why they failed last time. Believe they couldn't get gear down at all. So you know it's calcific. Just even if it's in the subintimal space, just go ahead and prep it. Short and rotor wire, one fiber, get it done. then take your microcatheter. At this point, it was actually a lot easier, kind of roto-save the day. Microcatheter went in pretty fast. Okay, what am I doing here? Okay, there you go. That's the microcatheter. Just slid right through. That was a fluoro save. And now you're kind of in the game. You at least have control of the antegrade part of the vessel, correct? That's a knuckle. Was able to get a guide extension catheter. I'm all set now. Now, flip and go retrograde. And so collateral was crossed really without much effort at all. And once this is done, this was a Corsair and a Sion. Distocap truly was at a bifurcation, so ADR is going to be high end if at all is an option. So once this was done, penetrated with a penetrated wire, and now you got to cross the collateral. So for this, again, a retro knuckle, antegrade knuckle, this is a guide extension reverse card pretty much. Again, no attempt to really wire this. Once I was in the vessel architecture, it was just knuckle. And I think Simon really illustrated the point. There's an art to knuckling. There's a lot of hesitation to knuckle in Asia Pacific countries, especially. It's a fairly safe thing. In fact, many times it's way safer than using penetrated wires. And once this is done, I just want to kind of really explain this for people that are not familiar with reverse card. What you are doing is you have an antegrade target with a balloon, and then retrograde wire gets into the space that the antegrade balloon has created. CART was actually originally designed where you had a retrograde balloon and the antegrade wire goes in, hence the terminology. And most cases, we these days do guide extension reverse card, way safer control. It's just much better. It's facile. If you can get a guide extension catheter, do it. Because it also obviates the need for shortening the guides in the retro limb. And it's much safer. You don't need to necessarily use stent, reverse card, etc. these days. And it also, obviously, once it's done, you can deliver gear a lot easier when you have a guide extension catheter. So here is the retro wire into the antegrade guide extension catheter. And once this is done, externalize the system. I'm just going to show this very, very briefly. This is courtesy James Pratt. But in essence, this is how you externalize. The wire goes, you put in a needle introducer, and then the retrograde wire, once it's out, this can be fed through the needle introducer, okay? And once you have this externalized, it becomes a lot easier. You just do your routine PCI. Again, you still want to optimize your results with imaging. And I won't waste time here. So this was the final result. How are we doing? Okay, I got 7 minutes. Okay, good. So sorry. So this case was basically done in about 2.5 hours on camera after all that I showed you guys. So this is another case that we did in actually in Chennai. So that's what you're dealing with. It's an circ. Friends don't give friends circs, but it didn't seem particularly challenging. But again, famous last words. My plan in this particular, and I knew that this again had been attempted before. So the thing that I didn't particularly like about it was I was like, well, I don't really want to go epicardial if I don't have to. So my plan was, okay, maybe we can resolve the proximal cap ambiguity with IVUS, tri-wire, maybe a high, ADR. If that doesn't work, retrograde. But lo and behold, could not make any antegrade purchase at all. Just didn't work. So decided to go retrograde. In fact, had to use a dual lumen catheter to even get into the epicardial. And once this was done, with some difficulty, that's again, SUO, as somebody had mentioned, has kind of changed the game quite a bit. So these were collaterals that honestly, I think you shouldn't try unless you're willing to deal with complications and unless the patient's horribly symptomatic. But this guy really needed it done, I was told. So, went ahead and did it. So SUO, Mike Caravel wired it. And that's the microcatheter. SUO03. This wire, I think I agree with Simon. I haven't perfed thus far with the SUO03, but too soon to tell. Anyways, once this was done, of course, this is the problem that I was kind of anticipating. It comes in at a really, really bad angle. So still have to deal with it. Was unable to penetrate the distal cap. As you can see, I'm trying some Carlino, which is injecting contrast through a small syringe to kind of change the game a little bit. Doesn't look pretty, but changes the kind of the whole architecture. Fairly ambiguous course. I don't want to go too far. As you can see, my microcatheter is still up here. So once I had enough Carlino, as you can see, already secured the the antegrade stuff so that the Carlino doesn't extend to the left main, or if there is, we are still securing it. That's critical. Once it kind of softened the whole thing retrograde with Carlino and an attempted knuckle, I was able to get antegrade wire down. Again, doesn't cosmetically look very good, but gets the job done. I just want to tell you, and again, knuckles typically are good, then the angle is not great. That's a bad, it's going somewhere, and I don't like it at all. So I was able to redirect it with a wire, though. And once this was done, I mean, the rest actually, just to kind of keep moving, once the retrograde wire was there, I managed to wire a branch that took off the circ, and then use the retrograde wire as a marker. So that's actually in a branch. Initially, I was like, did I exit it? But I hadn't, and it felt really good. But that's a branch that takes off the circ. And then use the retrograde wire as a marker to come antegrade. The key is, this wasn't my plan initially, but hey, sometimes you got to kind of keep it moving. It was safe. I knew I was in the architecture, and I kept going. And so now you have control of the vessel, essentially. Wired the branch, and then use the same dual lumen catheter after exchanging for a workhorse wire. As you can see, that's a workhorse wire just going in, boom, you're in the vessel. That's a cyan blue or whatever. And then the main branch was wired. Sorry, okay. As you can see, you're in the lumen. The rest of it, again, get your gear out, balloon, etc., and that's the final result. So just gonna, I think I got a few minutes left. So just gonna touch upon this really briefly. I think for those that are starting off, this is critical. Know how to manage the torqueable catheters. You want to, it's a one hand is to kind of advance it, the other hand is to torque it. Don't over torque the microcatheter, especially when you're starting off. It's an aggressive maneuver, so just be prepared for all kinds of eventualities if you're gonna over torque it. And again, in case you have difficulty, these days wires cross and then microcatheters don't. So the basics are, if the wire's already there, and if you can kind of trap it, that would be great, because then you can get your microcatheter across. Enhanced support, these are the basics. Obviously, if you want to change your equipment, that comes at a cost. You're going to need another microcatheter for that. And of course, if it's a septal, a cheaper option is to balloon the septal. Don't balloon epicardials, obviously. And I'm just really showing this to tell you that knuckling really is helpful. This is a case from China that I did. And as you can see, I thought I'm all set, but my antegrade wire is going into no man's land. And I have no idea. My antegrade wire and retrograde microcatheter are miles apart. And my retrograde knuckle, again, it tends to go somewhere, but I'm not sure as to where I'm going. And in fact, in this particular case, that is what we had to deal with. So it's a super tortuous RCA. There was no CT, so I had no idea. But once I was here, I was pretty confident that, this is just the natural course of the vessel. So then I got my antegrade wire, knuckle, microcatheter, and all this good stuff. So the rest of it, again, was guide extension reverse card, so I won't belabor this point. I'll just keep moving. So I got a guide extension catheter, knuckle, and then again, guide extension reverse card. So once this is done, you are kind of home free, all right? So the other key technique, and I think people need to know two more things. I'm not going to show tip in here because I think a lot of you are hopefully familiar with this. This was actually another case, supracalcific true osteal RCA. So number one, again, these are generally cases where you can never promise people, oh, you're going to get this. You can hope, because you really have just one option. So the collateral part, all that went fine, but now you have to retrograde wire true to true, right? And it's super calcific. Think use a CP820 for this. But once the once the, let me just let this play here for a second. This is the wire. You penetrated this, and the point of showing this case was not the penetration itself, but to snare. So once you're there, again, you want to confirm that you are truly where you want to be. So check a couple of views. These are always moments where your adrenaline level goes up. And here it is. It kind of broke free. You're in the aorta itself. And now you have to snare. There really is no other option. So I actually took out my AL, put in a JR4. I think I'm doing okay on time. And don't snare that wire that you use for penetration. Take it out. That's your RG3. And you are up in the aorta, right? And again, this is a skill set that I think people need to learn. And again, I always had ensnare when I was in the US. Now I'm in a lot of hospitals where I don't. And in fact, I like the homemade snare, which you can do with a balloon and a wire, because you can really control the size, and you got to move around. Don't be dogmatic on where you want to snare it. Typically, one of the great vessels, that's where I started. Here you can kind of see the wire come, the snare is here, the wire is it's in the descending aorta that we ended up snaring it. And once this is snared, you can kind of move the guide up and reseat it, and the rest is fairly, straight. I mean, the rest of the steps are what we normally do. Okay. Sorry, got to focus on the bottom part of the screen. So that's the antegrade guide sitting in. Once you reseat it, be really careful about what you're pulling and pushing. So this is done. And then, you got your microcatheter here. Now you can externalize as shown before and get done. So really, couple of things about retrograde: never pull. Usually that leads to bad things. Learn the steps of retrograde CTO PCI. Crossing the collateral of the wire, most people are like, hey, I'm done. That's just one part of the whole thing. Never dilate an epicardial. I think knowing retrogrades and being comfortable with it will enhance your success of CTO PCI. Requires multiple steps. There are lots of things where it could go wrong. So make sure you know the solutions. And again, having a good toolbox and having the skill sets is critical. And use proctors when able. And again, this is just the usual advertisement. July 9th, there's a charity event, so it should be a fun thing for people that have time to log in. I think this would be great for people that are interested in seeing CTOs from Japan to the US. So thank you very, very much. I'm going to stop there.
Thank you. That was great presentation, Arun. You touched on most of the components of retrograde. Obviously, you have to break down into 3 or 4 parts the retrograde PCI. Just one comment about using the snare. Sometimes if it is difficult to snare in the aorta, you can pass the retrograde wire all the way up into the innominate artery, and then it is easier to get snare in the innominate artery. You can take the GR4 guide catheter into the right innominate artery, and then it's a smaller area, easy to capture. But those are one of those things which you can catch wherever you like. But
absolutely. In fact, I'm sorry. I thought I showed you that thing, and my first attempt was actually in the great vessels. It didn't work. So the point I was trying to make is don't get dogmatic. If it doesn't work, try something else. Don't waste a whole lot of time in one particular area.
Great examples, wonderful skills. Can you just, for the academic purpose, can we just discuss what are the precautions you need to take in this retrograde Carolina, modified Carolina procedure, like you demonstrated for the circumflex? I think it is important for the attendees to understand, because someone should not just.
Absolutely. Simon, do you want to take this? Or I can give you my 2 cents. Just be really careful when you are doing Carlino, and especially when you're near some place like the left main. Yeah. In fact, yesterday, one of the cases that was shown, or was the day before, where there was a dissection that, that was Sanjog's case, I think 2 days ago, when he showed there was a dissection that extended all the way and shut down the left main. So you got to be careful always. like I said, that's a fairly aggressive maneuver, and you got to protect the other vessel. So ideally, you want to have a wire across so that if something happens and it's an uncontrolled dissection back into the left main retrograde, you got to be prepared to deal with it in case it gets shut down. But again, other than that, I mean, I think in many, many cases, it really does help you save the day. And sometimes you got to do what you got to do, as long as you know what you're doing, I guess. Simon, do you have anything to say about that?
Yeah, I think I would echo those comments, Arun, and it's just, you don't need to be aggressive either in the amount or the force of the injection. It's just it's a 2 ml syringe, preferably with the lure lock in the back of the microcatheter, and a very, very gentle advancement of contrast, not forceful in any way. And all you're trying to do is to stain up the target to resolve ambiguity. You will, of course, change the plaque during the hydraulic dissection, and that's fine. But if you're close to a left main and you're potentially going to take out an LAD hematoma, it's not a clever thing. So do be respectful of it, but you don't need to be forceful at all. It's all you're doing is trying to demonstrate anatomy.
One of the other things that's also very helpful to do when you're at the left main.
So that's the one other thing that I would say. Because a lot of this, we don't always routinely have it. That's a syringe that comes to the IVUS. So just be careful. I mean, I guess, as Simon was saying, it's like, you do have to generate some force to get through the microcatheter, but it is only as much as required. So it requires some degree of comfort with that. And don't use the syringe, the small syringes otherwise, because it'll break many times when you're trying to inject. Jay, do you want to
one of the points that I teach the fellows is when we're very close to the left main bifurcation coming retrograde is to wedge antegrade guide catheter extension into the artery that we're trying to treat. That serves as a safety marker. So the retrograde gear should never extend beyond that guide catheter extension. So it's sort of is a protection mechanism for the other branch. So I wouldn't let the Carlino stain get beyond the guide catheter extension. I wouldn't let a retrograde wire get beyond the guide catheter extension. That's sort of like the no-go zone. That's where we had to aim at the guide catheter extension rather than at the left main. It's just another level of safety.
I absolutely echo that. I mean, I think especially in osteal LADs, when we see people do it without a guide extension catheter, it always gives me, I'm like, why are you doing this? If you can get any purchase into the vessel at all, so please do that. It's always safer to get a guide extension catheter and then shoot for that. It's only in those times if you can't get it down, then yes, I mean, you got to kind of do it. But otherwise, I completely agree with that.
Great talk.
Can I make a comment?
Absolutely, Dr. Goel.
Yeah, actually, one thing that I often like to do when you are very close to the left main or something, and with a retrograde wire there, is if it's possible, you do a IVUS with a second wire, putting it into the circumflex or something, and then make sure that your retrograde wire is intraluminal, and then it's fine. So I often use a IVUS at that stage, so that you are sure that your retrograde wire is intraluminal. So then you don't fear dissection. So that is one way you can do it.
Looks like we are close to 8. I'm going to have Dr.
Two small points, Arun.
Talk, and then we can kind of come back. Oh, sure. One more.
Yeah, one is that you made a retrograde Carlino too close to the left main. So I think one should be a little wary about making it so close to the left main, and people should not get around by thinking that that's the usual practice. I know it was a bailout.
Knuckles in India, so I'm not even worried about people.
Yeah. So the second thing is about rotoblading into the subintima. You want to add a few points as to how you do it, when you do it, and what do you reserve it for?
Do you want me to take that? I've done quite a bit.
Sure, sir. Yeah.
I mean, the thing about the Rota is that it differentially cuts calcium and it doesn't actually damage elastic tissue. So it's like the boiled egg. You can rotoblade on it. It won't do anything to the egg. So it's the same concept. And actually, it's the only way you can modify calcium if you're in the subintimal space and you've got calcium in the vessel that's going to affect your stent expansion. So, I mean, I've done it many times. It is very safe to do so, and I've never seen a perforation. take a small burr. As long as you can get your wire far enough down, you can actually do focused proximal cap modification. You can knuckle it and shove it, or you can, as was demonstrated by Arun, you can cut a little bit of the radiopaque tip off. Leave yourself enough that you can still see, but it gives you a little bit more rope to work with. So it's a safe thing to do. It sounds mad and extreme, but
But for the benefit of everybody, why he's asking for cutting off that tip is because the tip is actually a 14,000 tip, so one has to be careful about the tip of a rotation wire. Thanks very much, Simon. I think we should, in the interest of time, go on to the next talk.
Guys, like, just to kind of reiterate, just one thing I want to say is that make sure it's never more than a 1.5 burr. I've never done more than a 1.5 burr. I don't think most of us do it anything bigger than that. So just be careful about it. That's the one thing that would add to it.
I would always be scared to do subintimal all the way unless my distal wire is through. I don't know. That's I appreciate what Simon said, but unless, because the distal wire is also in the subintimal space. So I am starting in subintima, ending also in subintima. So I wonder if incidentally the burr moves forward or something happens, it could go through and through. I would be a little scared. Well, I have not done the subintimal.
Dr. Goel, I think between us, I'm sure Jay has done it. Most of the hybrid,
Well,
I think we've done it a fair bit.
We have used it, and we actually cut off the 0.4 part of the rotor wire is, to some extent, so that we know what is the plaque modification we are doing. As much as what Simon pointed out, we don't have great experience or a large number of cases, but yes, it can be done, and that's what I was wanting to hear from Simon.
Okay, so let's go ahead. Let's go to
Jay, please, and then we can kind of save the comments for later.
Okay, great. Again, Arun, thank you so much for the invitation. Panel attendees, thank you for your attention. Can you guys all see my screen now?
Yes.
Great. So these are my disclosures, nothing relevant to the talk today. Simon already hit on this point, but I'm going to go back to it because my talk is basically about, if you've made the decision to go retrograde, what are the potential consequences, what are the potential complications, and what can be done about it? And this is important because what we see here from this slide is that the risk of complication is certainly quite a bit higher for retrograde than it is for any of the alternative crossing strategies. And this is complication rates in high volume centers with expert operators. So it just a word of caution for those folks who are getting started, maybe more junior in their experience, that this is an area where you have to be very honest with your patients that the expectation for a complication is certainly going to be higher. And that's the only way to achieve that very high level of success that we are reporting in all these registries. So let's just jump into a couple of cases and I'll show you examples of things that have gone wrong. So this is a patient who, once again, all of these are going to be retrograde. We're not going to discuss the strategy. They're all going to be retrograde, and I'm going to explain to you what happened in these cases. So this patient has multiple septal collaterals, which we thought were reasonable conduits to get retrograde to the RCA. But you know, the thing that you had to anticipate here is if you look at the base of the heart, so down here, there's a lot of foreshortening in this cranial view. But this is where you will see lots of tortuosity in the septals, and this is where there can be potential problems where you can damage these septals. That's usually benign, I'll say. So this is, after a prolonged effort, we were able to get a Shion black from the septal into the distal PLV branch of the right coronary artery. But we were unable to follow this wire with multiple microcatheters. So we tried a Caravel and we tried fine cross because those are the lowest profile ones that we use typically in our lab. We also increased our backup support using a guide catheter extension, and we also used anchoring balloons, and none of which allowed us to get to this point right here. This is where the microcatheter would not advance. So what did we do next? We took a 1.5 by 15 millimeter balloon. This is a Takeru Terumo balloon, which we use to dilate the septum. So here at the base of the heart, here mid-base, here mid-septum. And the balloon passed with no issues at all. So we inflated very gently to 8 atmospheres on several spots. And then thankfully, we were very relieved to see now the caravel advances very, very smoothly with no issue all the way into the distal right. Absolutely no problems at this point. So we proceeded on with our case. Now, once we got to the proximal cap, we did reverse cart conventionally with guide catheter extension. And we put a Gaia third retrograde into the antegrade guide and pinned it with a balloon. But despite all of this backup support, we're unable to advance the caravel through the proximal cap. And I want you to take a look at this catheter here. You can see how badly deformed the tip of that catheter is. And this is very, very important. If it takes this much work to advance a microcatheter through a cap, you have to be concerned about what's happening back here, because this is where all the tension is being applied in order for this catheter to be advanced. And you have to be cognizant of the fact that very, very bad things could be happening here. So we performed the procedure, IVUS-guided stenting, and this is a LAO angiogram. Something very suspicious right here. Very suspicious right here. And the patient starts complaining of severe chest pain. We didn't notice any ECG changes, and he was very hemodynamically stable, but because of this staining here, we became very suspicious that there was something going on in the septum. So then we took an RAO view, and you can see here that there's a rather large communication with probably the right ventricle from the septum. And we got a stat echo in the lab, and thankfully didn't see any other issues. The ventricles looked fine. There was no effusion. We didn't see any evidence of a left ventricular outflow tract obstruction, but the patient is complaining of progressive severe chest pain and getting a little restless on the table, but he's stable otherwise. So I took a second to break scrub. I called some friends. I called Dimitri at Columbia. I called my friend Bill Nicholson down at Emory. I called Bill Lombardi. And I got a bunch of suggestions, but the bottom line is the patient just continued to have chest pain, and we felt very, very uncomfortable allowing this to ride out. Now, normally when we have a staining in the septum, it's not that big of a deal, but we rarely find that the patient is complaining of chest pain, and rarely do we see this large of a communication. So the discussion that was had was to go ahead and just exclude this communication. So we put the fine cross down the PDA into the septal that was communicating and delivered detachable coils distally. Okay? And that's down on the PDA. And then we did the same thing on the other side. So we rewired the septal that we wired on the antegrade side, or the retrograde side, and put the fine cross back down this way and delivered detachable coils on the inflow side. And so these are the angiograms after a couple of minutes of waiting. And you can see there's no longer any flow. Now, what were the options here? We could have left this alone because most people report that septal ruptures are benign, but this patient was having lots of chest pain, and we didn't feel very comfortable about that. One of the suggestions that was made is to take a very sharp penetrating wire like a Confianza Pro 12 and maybe puncture a hole into the right ventricle to allow this to drain. I've never really done that. I don't have any experience with that, and I felt that if he was already having this much chest pain, that certainly wouldn't help the matter. But at any rate, the patient did okay. And it had a reasonable outcome and relief of angina with no long-term sequelae from what we did here. This is an epicardial case of a circumflex that has a stent here, and a previous operator had tried to cross the CTO and it ended up getting extravascular and caused a small perforation, which did not cause tamponade. The reason that we're going to go retrograde is because you can see that the distal cap is a bifurcation, so the plan was to go retrograde and not repeat what the first operator had done. And we were going to use this diagonal and that epicardial to come in retrograde. So this is a tip injection of a caravel microcatheter in the diagonal, showing how tortuous this, this epicardial is. And this is, again, SU03. We've mentioned this several times. So watch what the SU03 does here in the right lower corner. You can see how incredibly tortuous this collateral is. And this is an important point that I made to my fellow when we were doing the case. We had to pay attention to what the microcatheter is going to do to this tortuosity, because clearly the SUO is through safely. But what is going to happen once we advance the microcatheter through there? And you can see here, after we completed the case successfully, look at the shape of that epicardial, and look at the shape down here in the right corner. This is what we started out with, and look at what the shape is here. Now, when you see this, I always take pause. This is probably an epicardial that we have damaged because we have straightened it out. We've done a reverse cart. We've applied lots of tension to the system. We may have torn it. We may have avulsed it. We certainly have changed the natural course that this artery should have. And you should have a very, very high index of suspicion that this has been damaged. So typically what we do here is we leave the externalized wire across and place microcatheters down if we think that there's damage. And so you can see here that clearly the epicardial has been destroyed, but there's no bleeding because we have a plug-in from a microcatheter on the retrograde side and a microcatheter from the antegrade side. So he's stable. We did an echo just to make sure there was no effusion before we got it started, but this is something that's not going to seal. This has to be closed. And so we delivered detachable coils again here, but you have to have control of the inflow and the outflow like we did here. That's the only way that you can successfully close a damaged epicardial like this. And so we delivered detachable coils again from the inflow and the outflow side. And you can see on the top panel, there's still a lot of staining in here. The coils don't stop the bleeding immediately. You had to give this a little bit of time. He was stable, so we stayed on the table and watched him for a bit. And you can see after a while, the stain no longer washes out. And that's pretty reassuring, and there was no effusion collecting on the surface echo. So we felt very good about this. He spent one night in the hospital. Emphasize these points. This is an RCA CTO that we are planning on doing retrograde through one of these septals. And the case went pretty smoothly, with the exception of once we got retrograde, we were unable to advance the microcatheter through the proximal cap. We tried with a Caravel, we tried with a fine cross, we tried with a Turnpike LP, but even though we had a wire in the antegrade guide pinned with the balloon, we could not advance the retrograde microcatheter. So given the experience I had on the first case that I showed you, we decided we're going to leave this, and we just pulled our retrograde wire and put our R350 through retrograde into the aorta and snared it, and decided we would just finish the case that way. The biggest point I want to make about this is when you snare a retrograde wire, it produces a tremendous amount of tension on the retrograde system. So this EBU 3.5 that we have in the left main, the big mistake that we made here is we should have disengaged this from the left main, and we didn't. And I think we paid the price because of that, because this tension from the snare is sucking everything into the left main. And the best way to mitigate that risk is to just completely disengage the left coronary guide from the left main to minimize the chances of this happening. So this is a completion angiogram of the RCA. It looks beautiful, but the problem is the patient is incredibly restless on the table. And then there's a progressive drop in his blood pressure. And then you can see here on the ECG, look at his STs. When you see this, you have to be very, very suspicious that there is an issue with the donor artery. This should not happen after a completed successful case. And you know, the things to think about here is we use 3 different microcatheters to try to get through the proximal cap without success. So each one of those exchanges can cause the deep seating of the EBU into the left main. And lastly, using the snare without disengaging the left main can also cause some damage. And sure enough, you can see here on this angiogram that there's a dissection. And this is clearly from the guide catheter getting deep seated. There's no doubt in my mind that that's what happened here. Whether it was from the snare or from the multiple microcatheter exchanges, it's something that was avoidable. It's because of poor technique. The EBU probably wasn't it disengaged every time that we did one of these exchanges, and one of these times it dissected that left main. And the biggest thing to do here is once you see this is stop injecting. Put down an IVUS, find your landing zones, and lay the stent. And we did this, and thankfully the patient did just fine and had an uneventful recovery. So in conclusion, when you're doing retrograde cases, you have to maintain a much higher index of suspicion for complications, particularly donor artery or collateral channel injury. The first thing is to stabilize the patient. Block the bleeding with balloons and or microcatheters. Resuscitate the patient with fluids or intravenous pressors. Put in a pericardial drain if you need to. Provide an autotransfusion if necessary. Once you have that patient stable, then try to definitively repair what's going on. So if it's a donor artery injury, then try to get in a stent to take care of that. If it's a collateral channel injury, then you typically have to decide if it's an epicardial, how to get the inflow and the outflow taken care of. Septals often can be left alone, but in cases like ours where their patient is very symptomatic, those had to be embolized. In our lab, we use coils, but others have described using fat or thrombin or even beads. So certainly be familiar with what's available in your local lab. And the last thing is have a perforation toolkit on your CTO cart and be familiar with the equipment. One of the things that I always emphasize to my fellows is you don't want to learn how to use a coil in one of these situations. The best way is to be very familiar with this ahead of time so that you can handle the emergency effectively. One of the things that we do is we do a lot of structural cases here. And one of the things that we get referred a lot for is to coil lima side branches that weren't ligated at the time of bypass surgery for ongoing ischemia. So that's a great place if you folks get those type of referrals to try to practice using coils, to just get into a lima side branch and coil off the side branch. And so you can be very familiar and facile before you need it in an emergency. That concludes my talk. This is my personal contact information if anybody has any questions that they want to address to me directly. Arun, thanks.
Thanks, Jay. Thank you. That was a great overview of retrograde complications. And they are quite serious, these complications, and one has to be prepared for it and have all the kit available. And as you mentioned, that you need to be aware of what coils you have got, what delivery system you have got, what coil pusher you have got, and what system they are compatible with, whether you can use your own microcatheters or you need to exchange the microcatheter and use other coils. So that is very important, and you need to practice it. We also do.
Yeah.
Someone just muted him.
Lima embolization, and it's a good way to get some experience on with these coil embolization before you start doing in your retrograde epicardial perforation. So that was my comment.
Can I make a comment, Arun?
Sure, absolutely.
Okay, actually,
that was a great talk. And yeah,
for the retrograde procedures, I think I really appreciate the comments made by Jai Kishan in the last talk, because the donor artery, what I say is donor artery should always be respected. And this is a very crucial part of a retrograde procedure. And I would add to it that there are several times that donor artery may be having some moderate disease, maybe at the left main ostium or maybe in the body of LAD, which you are missing because there is no clear demarcation between a normal vessel and a disease vessel, just that it's long segment, mild, moderate. I think these are cases which will create problem because the retrograde procedure is going to go long and the guidings will always go in and out. And one has to be very careful, and one has to always maintain the ACT. Several problems in retrograde procedures occur because of a lower ACT. So the ACT always has to be more than 300. In our initial experience, I remember we had a patient where the donor artery collapsed only. We thought it was dissection guide catheter induced, but I think it was the ACT which was lower, and it was thrombus. So any disease in the donor vessel and any thrombus, so these things are very, very important in addition to the leaks and
very good points.
Yeah.
Has anybody else had issues with poorly therapeutic heparin lately?
Sorry?
No.
We've had whole batches of heparin that simply don't achieve a therapeutic ACT. That's
that happens sometimes. Yes, correct. That happens sometimes.
I believe that was a problem in the US.
China, not. I mean, this year has been good, and I think you're right. I think it comes in batches at times. You run into like subtherapeutic ACT for a while, but nothing recently.
I was just going to make a point, guys. You know, it's always simple to put a workhorse wire in your donor vessel and just leave it there. I mean, it doesn't really cost you much time or effort. And if you are to run into a problem like that dissection or whatever, you're safe. You're in the distal true lumen. You can drop a stent in, you know. So I would encourage people to do that in their donor vessel guide. Just have a workhorse wire down the bottom of the vessel.
Yeah, I completely agree, Simon. It serves another point too, is like, you know, if it just dive in, etc., you can always control the guide. Sometimes the wire helps stabilize it. I think that's very, very important. And also, if you run into trouble, I mean, it's your bailout thing. So there's no point in then scrabbling later on. And the other point too is about anytime you pull, you know, many times that's when bad things happen, especially in retrogrades. Just remember, these forces can, you know, things move around. There's other gear in. Anytime you pull something, think about what all is going to happen inside. Take a minute and then pull.
Yeah, Arun, you know,
these floss injuries can be very nasty. The flossing injuries which you have.
You know, this comment about when you pull, when you're going retrograde, pulling causes the guide to be sucked in, but it's a unique circumstance when you're pulling on a snared wire. That actually sucks everything in. So you're you know, it's the opposite, yet it still causes the same problem, and you have to be aware of that. Because normally you're removing catheters, you're pulling catheters out, and that causes the EPU to get sucked in. But in this situation, you're pulling a wire through, and it causes it to be sucked in because it's actually pulling the entire system antegrade.
Actually, in addition to the guiding getting wedged, you can also strangulate the heart totally. The entire system can get, because you're shortening the entire system. So your collaterals also can get torn. You know, that's where you can produce tears and perforations in your channels, and the entire heart gets sort of strangulated.
But Jay, the example that you showed with the floss injury in the epicardial, in fact, once the wire and the microcatheter do cross the epicardial, most of the tortuous epicardials do tend to straighten out. So it's not really very unusual to think like that. But we have to kind of reduce the tension on the wire to ensure that the flossing effect doesn't happen.
Yeah. Well, I mean, that's the point I'm trying to make. So despite being aware of that, despite discussing it, despite talking about it during the case, it still happens.
Yeah,
it just simply cannot be avoided. These arteries are so fragile.
So in every lab and every operator has his own bailout toolkit. So we have Sudhir, Arun, you, Praveen, and Simon here. What would be your coils of choice which you would like on the shelf? And because we all know the challenge with the diameter of most of our microcatheters, they don't take many of the coils unless you have neurocoils available. So what is it that you would like on the shelf all the time for a quick bailout? And what is it that you would like to tell people who are, you know, starting retrograde interventions to have with them before they start these retrograde cases?
Sure. You know, one thing to point out is that fine cross can accommodate 018 coils. Okay. So if you use fine cross, you actually have a little bit more options available. Whereas Corsair, Caravel, those catheters can only accommodate 014 coils. So you have to have neurocoils available. So in our lab, we keep Axiom Medtronic detachable coils, which are 014 compatible. So we can put them on any microcatheter that we have in the body. But if that's not an option, fine cross can take any 018 coil.
And when is it that you've been using fat or thrombin in your practice? Simon made a point that he would like to have a top-up protamine given after every perforation has been closed. But all the same, I would like to know, when is it that you choose alternatives like fat or thrombin?
They're good. They're good for distal wire exits, so they're not particularly good for collateral channel injuries. But if you've had a wire go out the bottom end of something, fat or formed thrombus will actually usually solve that problem. So if you're down a little side branch of something, you can drop them in there, and they'll solve a leak there. But they're, you know, it's just not great for a proper epicardial rupture or a septal problem. So I think you need to have several possibilities. I mean, fat's free. It's great if it's going to work. You don't have to spend any money. And it's very easy to do. You just take a little chunk, usually from the groin, turn your Corsair up because the fat floats up, poke it in, and then send a wire down behind it. but it's typically for a wire exit rather than anything else.
I agree.
In my hospital, I've got, I think ideally you should have a 0.014 compatible coils. We have Cook coils, which are 0.018. So we have to put the microcatheter coil pusher and the coils and remove your microcatheter, which you are using for CTO. And we have done that. And obviously for the wider audience and the participants as well, when they're starting on the CTO, when they finish the case and then the time for high five. So never remove the wire completely out of your retrograde collateral and just pull the microcatheter back into the donor artery and take an injection to make sure there's no damage, because once you have pulled everything out and then you identify perforation, it might be too late to wire it. So leave the wire always there, your externalized wire, and then take it out so that you have got control from both antegrade and retrograde if you need to put any coils. And as Simon and Jay said, I think FAT and thrombins are mainly for wire exit perforation, but coils are very important for epicardial, and sometimes you need for septals as well.
Completely agree with all the comments that were just made. I mean, the one thing I would tell you, I mean, India, for a country of its size, I think we don't do enough retrograde. Well, we don't do enough CTO PCI. We definitely don't do enough retrogrades, or ADR for that matter. But in any case, the point I wanted to make was, if people are going to start or embark or serious about doing retrogrades or CTOs for that matter, definitely get your feet wet with septals, juicy ones. I mean, use a practice if possible. Learn the steps before. I mean, any of the cases that I think, I mean, the ones that Jay showed for sure, the second one that I showed, or even the first one, make sure you know the steps really, really well. Get those juicy collaterals. Get comfortable with all the steps before you start playing around. I mean, a lot of these techniques are probably fairly high end. Hopefully the audience kind of got some of that. But I think as basics, as Sudhir said, make sure you do your check angio. Don't pull the wire out. No, be prepared for complications, etc., etc. I think those would be really, really good beginner steps. Ajit, you teach a lot of fellows, and so does Dr. Goel. So you guys, and Dr. Azam too, you guys are in teaching institutions. Any tips and tricks, and what do you think like we can do to kind of get the next generation more comfortable with this, as opposed to this being some exotic thing that only few people can do?
Sorry, can I just ask one question from the Indian operators? You've got opportunity, Dr. Dhal, Dr. Goel, Dr. Pillai, and Arun as well. You guys want to comment on? I have seen cases from experienced operator about the cath lab homemade coils, because many times the coils are not available. You guys cut these 0014 radio opaque wire and make your own coils in the lab sometimes. Do you want to comment on that as well? Yes, Ajit. Sorry.
Yeah, cut the 014 and then make it into a coil, and then it's just a free flush, and then push the wire. This has been, but nowadays I think we have these were done during times when we had difficulty in getting the coils. But nowadays I think once the CTO program has been established, I think we always keep it in the shelf. We had actually difficulty, as you were suggesting, with 018 coil doesn't go through a Corsair and Caravel, which is a Varco's retrograde microcatheter. Of late, Medtronic has come with 014, which is thanks to their association with the Covidian, which is a neuro coil maker. We have now relatively free availability of this 014 coil. We used to do this 014 wire stripping and then putting it into the coronaries for this perforations a while ago. But nowadays, I think we have enough dedicated stuff in the cell.
Guys, given the time, I'm just going to say first, we can continue those that have the time. Thank you so much, each one of the panelists and the speakers, Simon, Dr. Goel, Jay, Ajit, Dr. Azam, Sudhir, Dr. Dal. Thank you all so much for having taken the time and having contributed. Thank you all the attendees. So tomorrow, 7 o'clock, we're going to just have complex PCI. The CTO part is kind of over. You guys, we can continue the discussion, but if anyone wants to leave, please. Really appreciate your time and effort. Thanks a lot.
Thank you. I think we can.
Yeah, I would like to thank Arun for organizing such a great program, and Simon, Jay, Arun, the talks were excellent, top of the notch, and obviously covered most of the retrograde issues one encounters in day-to-day practice. So thank you all, and nice meeting you, and stay safe. obviously this corona pandemic is changing the work patterns, and these conferences are becoming
Thanks, Arun,
common practice.
for the.
Thank you,
I just
Arun.
would like to-
Great
Yeah,
evening.
very good.
We could see each other, and thank you for having us.
Yeah.
And
Thank
incidentally,
you, guys.
all of your cases were out of syllabus. You know, you all try to show things which everybody's going to run away from doing retrograde CTOs.
Well,
Okay.
we have an India Live CTO case that's online, so that's a pretty basic beginner retro case. So I mean, that's on. So
Thanks, Arun. It was a nice session. And my only comment, last comment would be, for all these CTOs, most important thing is to understand the angiogram. So I think this is something where all of us are missing. This is the only thing we take for granted. And that is the only thing that probably we are missing. So a very good understanding of the angiogram will take you a very long way, because you need to interpret the pictures right and everything will go fine. So that's
Thank you, Arun. Thank you, Arun, for your wonderful program. Actually, one comment I should make: the CTO really is a tough, complex procedures, but more tough is the planning. If you have a proper planning, then that gives you significant insight to outcome of all over the complications. So you should make a proper planning. I think it is the best option, and every operator should consider before procedure what complication may happen. He should predict what protective gear he should need. He should arrange his cath lab. Then he go for these CTO procedures. I think that is my comment. Thank you very much.
Thanks, Arun. Thanks for the wonderful session.
thank you, guys.
Thank you all.
Thank you, Arun, and thank Jay, thanks Simon, thanks Sudhir for joining us from overseas, and thank you for organizing.
Thank you.
Thank you very much.
Thank you. Nice to meet
Guys.
everybody.
Stay safe.
Thank you. Nice meeting you. Thanks, Simon. Thanks.
Bye,
Cheers,
Sudhir.
guys.
Bye, Anil. Bye. Bye, Arun. Thank you.
Thank you. Thanks, Sudhir.
Thank you. Thank great. We'll join later on. Yeah.
Sure.
Join
Stay
again.
safe. Stay safe.